we look at all of those things when we're trying to determine if a patient has a tongue tie or not. The reason this is important is because the tongue tie will hold the tongue out of the palate. I think we all learned about this. I'm pretty sure that I learned about this in hygiene school, but I don't know that I really used it until 2014 when I had one of those 2x4 moments where everything came crashing down on my head. And this is what we see a lot of, and this is what we want to see. The pressure of the tongue against the palate from infancy on with the competing muscles of the cheeks is what sets the size of the palate. Without the tongue in proper occlusion into the palate, then we have a narrow arch, a narrower arch. And there's a lot of different things, different dominoes that happen on account of that. So this is another little diagram of good tongue posture from the side. In this first picture here with the green check mark, the entire body of the tongue fills the entire oral cavity. And in the second picture with the tongue low, and I added that little 2-pointed arrow there to show that there's space between the tongue and the palate. And look what happens to the tongue back in the airway. It kind of slumps into the airway. So that's a really big problem, and that's one of the ways that snoring occurs. We don't know what's going on until we start asking questions. Is this really a carious situation, or is it a sleep apnea situation? Is the patient breathing with their mouth open? You know, obviously this could be a person on drugs. It could be a lot of other things. I'm just using this as an example to drive this point home. It could also be periodontal disease, and it could also be diabetes. So we need to do more investigations as we are looking at our patients. We need to realize that an idiopathic deviated septum needs to have dental impacts after the surgery. Just because the septum is now straight doesn't mean that the patient now knows how to breathe through their nose. So once that deviated septum is repaired, so how did it get there, right? We're going to ask why. Why is it here? Because the arch never developed, potentially, right? But the brain was growing. Because the brain is growing, that's what sets the size of the head, the top of the head. The tongue placement, tongue mobility, tongue pressure with competing pressures of the cheeks is what sets the size of the maxilla, and the mandible follows. Look for clues in the mouth. Remember that this is not a throat, it's an airway. Decide in your office, are you going to use the tongue out measurement or the tongue in measurement in order to make an assessment of the occlusion of the airway, the oral airway? Those are really important things that you can be doing in your practice.